Hello, everyone. Thank you for joining us. We are going to get started in just a minute, waiting for some folks to trickle in and join us on the webinar. We're so glad that you're here. Thanks for joining. This is the Lessons from the Learning Initiative, Promising Engagement Practices. This is the third and final series in this summer sprint that we've been doing since June. Today, we're focusing on staff and leadership engagement and what that looks like to build culture and respectful care on your unit and in your community. Thank you all for joining. Got a good number of folks coming in. We will have the Q&A live and ready for you all. So please feel free to add your questions. We hope that you have a good time in hearing from our presenters today. I will go ahead and get started. Thanks for joining us. As a reminder, this is Lessons from the Learning Initiative. We're glad that you all are here. My name is Savannah Gray. I'm the Clinical Program Manager with CMQCC, helping manage learning initiatives. So really excited to share what some of the hospitals that we've been working with have been doing and some of the great practices that they've been able to put in place. As a reminder, all attendees are muted upon entry. You can utilize the Q&A to ask us any questions. Our presenters will be answering them after their presentations, so you can connect with them there. Please don't copy the slides. The slides will be posted on CMQCC's website for you to go back and view, as well as the recording. And please send us your feedback. We'd love to know what other recommendations you have for future webinars, what else you'd like to learn, who you'd like to hear from. We're here for you guys. As a reminder, recording and slides are going to be posted in the next 48 hours on cmqcc.org under our Education and Research tab under webinars, where you can find a lot of other webinars that we've done in this summer as well. All right, this is what we're going to be talking about today. I'll give you a brief introduction to the Learning Initiative if this is your first time. If you've never heard about the Learning Initiative before, we'll give a brief reminder and kind of an understanding of what that looks like. And then we're going to hear from UC San Diego and Hoag Hospital today. I'm really excited to share you a little bit more about what they're working on. And then we may have time for a brief Q&A at the end, but we do encourage you to put your questions in the chat throughout the presentations. All right, introduction to CMQCC's Learning Initiative. The full title of the collaborative is the Learning Initiative to Support Vaginal Birth Through an Equity Lens. This is a CMQCC Quality Improvement Collaborative that began in 2022 with funding from the CDC. We have a couple more years left to keep this thing going, which is great. We've got 5 cohorts that we are planning for the Learning Initiative. Each of them are about 18 months long. And they're built upon the learnings from previous CMQCC collaboratives, including our Supporting Vaginal Birth Collaborative that was through 2017 and 2019, and the Pilot Birth Equity Collaborative in 2019. You can learn more about those at cmqcc.org if you're interested. Some of the goals of the Learning Initiative primarily is to reduce the disparity gaps that we see in low-risk cesareans with a goal of all patient groups reaching or exceeding the Healthy People 2030 target of 23.6. And within that larger umbrella, we're really trying to see those racial and ethnic differences reduce, increase participation of hospitals that have higher NTSV cesarean rates, increase community and patient awareness of NTSV and different racial disparities that exist, and increase the number of hospitals with patient and community engagement practices to reach this goal and reach these ends. The curriculum and education training for the Learning Initiative covers a range of quality improvement practices, cesarean work, and equity education. With an 18-month collaborative, it's quite a long time to work on a lot of areas. So we try to touch a lot of different pieces. We want to touch quality improvement fundamentals, understanding how to conduct baseline assessments, really work on implementation science practices, dive into respectful care and what that looks like, and leverage a lot of the tools that CMQCC has developed, including our maternal data center and our hospital action guide for respectful and equity-centered obstetric care. We do also have quarterly webinars included into the curriculum on health equity and cesarean work. Those are our Let's Talk Perinatal Equity webinar series, which you can also see on cmqcc.org. We really want to highlight that the Learning Initiative is about building blocks of culture change. It takes a very long time to shift unit and hospital culture and community culture towards one that supports, promotes, and embodies respectful care. And it takes testing and iteration, those PDSA cycles, of different building blocks to understand what works on your unit in your culture. So part of what we like to do in this Learning Initiative lessons webinar is highlight what those different building blocks look like for different hospitals. Today's presenters are UC San Diego. We've got Ayla Garza and April Ricotta. They're actually in round 2 of the Learning Initiative. And then Hoag Hospital, which is locations in Newport Beach and Irvine with Tiffany Stewart and Trina Rains, and they were in round 1 that graduated last year. So without further ado, I'm going to pass it off to UC San Diego. Thank you guys for joining us.
Thank you, Savannah. I'm Ayla Garza. I'm the Senior Nursing Director for OB, Newborn, and Neonatal Nursing at UC San Diego Health.
Hi, everyone. I'm April Ricotta. I am the manager of the doula program here at UC San Diego Health.
We are very excited to bring to you today our pathway that we took from our inquiry to sustainability in our project of expanding our existing volunteer doula program into a more health equity based program. We'll walk through the steps of how we got there. So we just wanted to hear from you a bit in our audience to see who we are, who we have out there. So Savannah has a quick little survey. If you guys want to start selecting, can you all see that? Hopefully. I don't know if we've tried this before.
Yeah, we've got some answers coming in.
Okay, good. You'll have to read them out because I can't see them.
Okay. Yeah, we've got about 40% saying they're convinced, but now what?
Good.
About 35% saying this could work here, but they're exploring some feasibility. A few folks saying they're ready to launch. They have resources and support.
Awesome.
Not very many folks asking what's a doula. Seems folks are kind of more in that feasibility and seeking implementation phase. And a handful of folks talking about their scaling up, but definitely more in the exploring feasibility and seeking implementation guidance.
Perfect. Okay. You can advance.
See, I can share those results with everyone now.
Oh, yeah,
there we are.
Perfect.
Amazing.
So hopefully we will address something for everybody. We certainly work through each one of these steps, and we did it in, I would say, in UCSD's timeframe at the speed of light, which was about a year. So I think the Learning Initiative support was a great launch to a lot of these ideas. So thank you, QMCC, for being with us along the way. Okay, next slide. We're going to talk about how we got started. Go ahead. So creating momentum, really the time was right. We used that momentum to move forward. Of course, we had the longstanding doula program. Some would say it was a big success, but after 20 years, some also really wanted a shift. Maternal health equity is, of course, a very big critical public health concern. And there's been a lot of federal health policy support for doula care. This is just a brief graph of the increasing policies up till 2020. So April had some experience with on the receiving end of that.
Right. So we had an increased interest in people volunteering, wanting to be part of our doula program. So really expanding that option. We had an increased demand for doulas from our patient populations looking for more support, but also within that policy change, we had a lot of patients looking for how can I utilize my insurance to get doula support, and what insurances are doing that, and how do I make that claim, and how might I find a doula that really matches my needs?
And we weren't sure how to answer all those questions, but we could definitely see that we had a practice gap. So we went to the literature to see how we could respond because we knew we were in a good position to do so. Next slide. Again, next slide. So we began developing our plan. And I could talk about any point of this slide, but to keep it as a high-level overview, we use the evidence as a strategy for leadership buy-in and program success. It depends on your culture, but we know here that we are pushing evidence-based healthcare at all times, so we knew that that would be a success marker. In reviewing the literature, as a refresher, doula support, of course, has positive benefits. The outcomes are not always consistent, and they certainly improve cesarean births, definitely experience. The quantitative metrics are a little bit more not conclusive in some studies. And I think it has to do with a lot of the methodology in doula support, where it's very difficult to control for confounding variables. There is selection bias, where the people who are participating and having doulas are different than those who are not opting in for doula care. Or perhaps it's a lack of access. Maybe they want doula support, but they don't have it. Again, in the literature, a lot of the articles weren't very specific on their training standards, what they considered doulas, and how long that the doula was with the patient. Was it prenatal, intrapartum? Did it include postpartum? So there is some limitations. Conclusively, though, if you filter down the data by race and ethnicity, certainly doula support is more conclusive in the positive effects for Black birthing people and publicly funded births. None of the case studies or systemic reviews had any evidence of harm, which is great to note. And then another outcome of the research is that community doulas and birthing people of color both face systemic barriers and institutional barriers, and that doula work should be reimbursed. So that is where we pivoted in the direction towards using our volunteer program and finding ways to create opportunities for people within the community who may be facing those barriers to come to our organization, become trained, and then we can match those doulas with patients of that same culture, experience, or language. We did use the CDC program evaluation as a framework because it really talks about engaging collaboratively with the community, advancing equity, in a very specific PDSA type version. Okay, next slide. Dissemination, next. So I'm speaking of dissemination as like the very long messaging in advance to improve success of our intervention. So here, like we did a big, maybe some people refer to it SWOT analysis, like the internal assessment. How ready is your organization for change? Is it the right time? Again, working with that momentum and finding the right opportunity. So we have a high birth volume, we have 2 locations, and within our specialty, we have a decentralized decision-making. We have autonomy to make big changes as long as it's mission and goal focused. We have a very clear UCSD goal that they want to improve health disparities and, of course, keep finances within budget. So we were within alignment. So we did make autonomous moves with support of our colleagues, our physicians, and we'll get more into those details, but the organization in general has a very big culture of innovation and change. And of course, we already had the doula program to work from. Next slide. We also had to consider the external environment, which was questionable at best. We have the right population. We have a big immigrant and refugee population, 22% in San Diego. 41% in San Diego County speak a language other than English. So there is a lot of need. I just included a map of our delivery zip codes just to show the span of people coming to UCSD to give birth. You can see our like literal maternal desert stretching across the Mexico-US border. And a lot of our community partners that we worked hard to have relationship with and referral networks. In March, there was a big investigation to all of San Diego's groups that were helping new refugees, asylum seekers, which UCSD absolutely was. So it became very unsafe feeling to advertise our new program, to request like registration. So we really had to make sure that we were promoting cultural sensitivity in all of our forums, whether it was recruiting, training, obtaining consent for photos, really proceeding with caution. And any of our advertisements for training, education was very much done with specificity. Next slide. And we are at the halfway mark, right on schedule, our implementation roadmap. Go ahead. This is how we did it. This is our recipe to success.
So it took several attempts and steps and conversations in order to start to translate that evidence into practice. We did have a longstanding program, but we needed to really look at our curriculum and enhance it and update it to meet the needs of this population, ensuring that we are culturally sensitive, that we are integrating all different new research components for this community doula group. We also really wanted to integrate and invest in both internal and external structures. So in our recruitment, we needed to look at our community groups, our engagement. Internally, we really needed to make a plan that was going to be sustainable for this group. So we needed to talk to risk and compliance, population health, which was how do we do home visits? Can we do home visits? It was a new program to our longstanding old volunteer program. We also knew that this was a group that we wanted to be able to give some remuneration, some reimbursement. How are we going to do that? How did we engage with different players? Integrating these doulas in with our volunteer group and our current clinical team was paramount to success. So we had people from all different disciplines coming in for looking at the curriculum, partaking in the training, as well as the mentorship. When we looked at the design outcome monitoring, we really started that from the very beginning. So we wanted to look at quantitatively. So we set up new mechanisms within EPIC, and then qualitatively, we set up some surveys for both patient satisfaction, staff satisfaction, as well as the doulas themselves. Next slide, please. This was truly a collaborative effort. So you can see from all of our lovely logos here, we had to discuss and plan with a whole bunch of different groups. We worked hand in hand with the Refugee and Immigrant Health Unit to really do all of the grassroots recruitment and engaging with community. They worked with us with our training curriculum as well as the onward movement. We also worked very closely with human resources to try and develop a guide and a plan of how can we get these doulas reimbursed? How can they look a little bit different than our volunteer doulas? How can we value their presence and ensure that they're being engaged? We worked with the OB refugee program in order to engage patients in a referral process with these doulas to match them culturally and linguistically as well as experientially, making sure that we're meeting all of the needs. We really had to get out both internally and externally to meet all of these players, introducing ourselves, introducing our goals, and ensuring that people were buying in, we're understanding, and we're contributing to this pathway. Next slide, please. So you can see on this roadmap, as Ayla said from the beginning, it did go light speed. Do you want to talk a little bit about the first portion?
Our success was really grounded in relationship building and dedicated leadership. April. So she's a worker, but like you can see on this roadmap, we certainly wanted to point out we've been working with these community groups, trying to build bridges and create relationships since 2021, perhaps longer, but officially I would say January 2021 when our border policy changed and we were inundated with groups crossing the border that we had not experienced before. We could not match their cultural needs, their language. So we started beginning our relationship then. Sometimes it went well, sometimes it didn't, but it was there and it took a long time and the seeds were laid for ongoing relationships. Certainly joining the collaborative in April of 2021 really helped solidify that we were moving in this direction. And then in July 2024, that's when we really started making some changes and doing outreach.
So this was when around that time, somewhere between July and October, we really started to realize, okay, we need to expand this doula program. We need to meet the needs of our community, of our patients. So we looked at the literature. We did some discovery inside and outside, both hospital-based and San Diego-based. We engaged with our internal and external partners, and we were able to continue to bring in a larger volunteer doula program. So you can see we doubled up. But then we really got moving towards the training of this new group of community doulas who were supporting our recent immigrants, refugees, and asylum-seeking obstetrical patients. So we did our training. It was 2 days. We then engaged them with mentorship with our current doulas to ensure that we were meeting all Medi-Cal requirements. They were getting supported through 3 mentored births. We then enhanced their training with both antepartum and postpartum training to facilitate their ability to support our obstetrical patients in the antepartum period, through intrapartum and then through the postpartum as well, because we know that that was really where our patient experience is enhanced. We then did increase to just look at some other things within our scope of the volunteer program, postpartum, as well as a nursing student doula component. But what really was exciting is as we continue to grow this community group that was supporting our newcomers population, is they were getting signed up for Medi-Cal. They were having their mentored births. They were having amazing patient experience. And we had a fantastic celebratory graduation celebration for them in July. And they all continue to support these patients that we know have this need within our community.
Next slide. Okay, one more, next slide. So maybe I'm alone here, but sometimes when I launch a new project, I often forget about this piece of really measuring outcomes. But we really want to contribute to the gap in the research. We want to make sure that the program we are designing, because we know there was no roadmap in the literature, we want to make sure that we are successful or that we're at least demonstrating whatever outcomes we have. So we did set up SMART objectives and measuring our birth experience of our patients and our experience of our team members supporting those births with culturally matched doulas. We also are, as a process outcome, we are assessing how many requests that we can match within a week with a culturally similar or experience or language, how many matches we can make within a week. And then we gave ourselves some time here to bring up our N size, but we will be measuring our cesarean birth rates with our patients who receive culturally, linguistically matched doula support.
Currently, even though those N sizes are small, we are measuring both qualitative and quantitative. We're meeting match requests within the week, and our current NTSV C-section rate is 20% for all of our matched doulas and patients, which we're super excited about.
And we definitely want to, like I said, submit for publication when we have our data. Next slide. Key takeaways. Good, next slide. So definitely don't forget about the research. I don't think anyone really does, but it's really good to bring it to the forefront. You can use it as an engagement strategy and for your own enhancement too, to be able to speak confidently to it. There's so much in there. So use the research. And then if your resources are limited, which many of ours are, figure out a way to prioritize to match those patients most at risk with doula support. And then work on engagement, reaching out and supporting community doulas and our community groups, and make sure that they can thrive in our inpatient clinical setting, which can not always be a most familiar settling place. And then try to create a path for reimbursement. I mean, there's no right way. We're trying this way. We hope that it will continue to grow and improve, but this is the way we started. And then really think about your internal and external environment. Use that momentum, come up with a full dissemination and implementation and evaluation plans. So you, like us, will hopefully contribute to that body of knowledge to support doula access.
A doula isn't a magic bullet. They're not going to solve everything, although we have found amazing anecdotal response and qualitative responses as well as that quantitative. But we need to remember that doula support alone is not going to fix structural racism and health disparities that birthing people of color experience. But initiatives like this together, we can learn, we can share, we can publish, and that will make the difference.
Savannah, do you want to do our third poll or second? Whichever one, or both.
You wanted the second or the third, or both?
Depending on time.
We can do both.
Okay, let's do second.
Okay.
So we just wanted to take a poll, like what do you think you guys would need to celebrate your program timeline?
And I'm going to leave it up for a minute or two.
Mm-hmm. Executive support, funding, better partnerships, a blueprint, or a dedicated leader. What do we have?
Most of it coming through is program funding.
Mm-hmm.
Second and third in the lead are evidence-based toolkits, blueprints, and then executive support.
Good.
Fewer responses on dedicated leaders.
Good.
Let's give another few seconds for some folks to answer the poll.
Okay, I think we can see, so we can save time for the last one.
Funding is a challenge. We're with you.
Yeah. Toolkit was the other challenge. Yep.
Mm-hmm.
Good. Okay. And then we have one more poll.
Go.
Okay.
How likely are you to advocate for improving access? I'll leave that one up for a minute as well. Folks want to go ahead and answer those.
So how likely are you to advocate for improving access to doula support in your organization?
So far, mostly very likely and likely.
Awesome.
That's great.
Yeah, we love to see that.
Well, we are here to support you. If you're able to go to the next slide while the poll is going on. We have a great group of collaborators. These are our team members that help move this forward. And please reach out if you ever have any more questions. Ooh.
There they are.
Cool. Likely. That's great. That's great. Well, we're here to answer any questions. Thank you guys so much. Lots of references. There's probably plenty more and our contact information.
Thanks, everyone.
Awesome. Thank you guys so much. We really appreciated that presentation. It was amazing. There's lots of really good advice and best practices in that. You guys have done an excellent job. We absolutely love getting to walk through that with you in the Learning Initiative and hearing about putting those pieces together and understanding more about what it looks like to get your staff and your leadership engaged and build on what has worked in the past. I think that's a really big key that we like to reinforce in Learning Initiative is look at what else is working in your institution, what else is working that's maybe not related to the program you're trying to really put forward, but what are the facilitators that have worked in other ways that you can replicate and move forward in new programs that are effective like this. So thank you guys for joining us. I'm going to move on to our next presentation from Hogue. We've got Tiffany Stewart and Trina Rains here. Tiffany, you'll just have to put your camera back on.
It says it's disabled by the host.
Oh, let's see if I can fix that for us. Hold on.
This is a collaborative effort.
There we go. There it is. Okay, great. Thank you guys for joining us, and I will pass it off to you.
Awesome. Hello, everyone. We are so excited to be talking to this group today. So I'm Tiffany Stewart. I'm the Executive Director over Maternal Child Health at Hogue, overseeing both campuses of Irvine and Newport Beach, but I am a labor nurse. I've been a labor nurse for 15 years, and I actually started at Hoag 12 years ago as a staff nurse.
And I'm Trina Rains. I have worked here at Hoag for 22 years, all of my career. I also was a Hoag baby in 1973. I have served in many areas, including the emergency department, peri-op, labor and delivery, maternal child, and also in various leadership aspects. But I have returned to the bedside and currently serve as a clinical ladder nurse and chair our birth equity committee.
All right, next slide. Thank you. So every maternal child health meeting, presentation that we do, we always lead it with our vision that we have at Hoag for our service line. And it's to be the safest place in California to have a baby, to be top choice of maternity services, and to be ranked nationally for all maternal and neonatal outcomes. This slide's one of my favorite slides. So all of these photos are either, our patients laboring in the Irvine campus or Newport Beach campus. But today we're really going to emphasize our cultural journey with our leadership team and our nurses. That bottom right-hand photo is a photo of our labor room in Newport Beach with a birthing tub. Being a staff nurse previously in Newport Beach, we would have never guessed that photo that would ever be a thing here. The word midwife, we would say, used to be a bad word.
We're getting a midwife transfer.
And
that would be.
And so we've really committed with our team to go on a cultural journey, to adjust our mindsets and really lean in on supporting our patients and the birth that they choose. Really, and it's all driven by our care team. Did you want to talk about spinning babies?
Yeah, I think one of the examples we like to give is many of us kind of took it upon ourselves to start taking spinning babies classes, and it started to catch on, and we would get new staff who would bring that skill set to us. And in true nurse form, we became very resourceful, and we would pass these skills to each other, then start taking formal classes. And the doctors would, be like, "That's silly stuff. That doesn't affect anything." And then now we're to the culture where a doctor comes on and they're like, "Can you give me a nurse that's really good at spinning babies? I really want to get my baby out," and so I think that culturally it's a huge shift. So very neat to see.
We're proud. It was a journey, and we're going to talk a little bit about that journey.
Yes.
And so I just want to emphasize our care teams are extremely large. There's over 600 of us in our maternal child health service line, and we float across campuses from Newport Beach to Irvine and throughout our departments through NICU and mother baby. And so it was really important for us during this collaborative to ensure that we are inclusive of our whole care team and not just focusing on one group of staff. And so we truly believe that it takes each of us to make a difference for all of us.
And I think I liken it to steering a cruise ship. It's big, it's unwieldy, but we get us all doing the same thing together.
All right, I'm going to give just a brief overview of each campus. So this is Hoag Hospital, Newport Beach. Every single month, we do just about 600 deliveries in Newport Beach alone. It's the traditional labor and delivery. Postpartum is in a different unit. And so one of our providers likes to say we deliver a kindergarten classroom every single day. I did want to add the link on there. If you're interested, you can take a little tour of our unit on the YouTube video. And we also have a level 3 21 bed NICU. And for Irvine opened December 8th of 2020. They have a large midwife population here. So our midwives in Irvine do over 40% of our deliveries. Our patient population that chooses Irvine, we have many suites, but we have traditional queen size beds, and it looks like a queen size bed. And the midwifery care and the patients choosing physiologic birth there is extremely high. Our epidural rate is about 50% compared to Newport Beach, it's about 95%. And I think the uniqueness of Irvine is we had one large obstetrical group that was delivering specifically in Irvine, but since February now, they've been delivering at both campuses. and we have over 82 OB providers that deliver with us.
And it's fun to see as the two hospitals merge together, and Hoag is expanding and or Irvine is getting bigger and expanding to be almost the same size as Newport. As the Irvine group comes and the staff goes back and forth, how the two cultures are merging. The Newport Beach used to be heavy, big, go, high risk, all the scary things. And now it's great to see us mesh together and each of us combine our things that we're good at.
And I think just to note, for collaboratives, for quality initiatives, we know that we have to be aligned in one Hoag and doing things the same on both campuses, but having all the different providers involved to really see the change that we need for our patients.
And we will say this does come with pain points, and it definitely stuff we worked through, but I feel like currently we're getting pretty good.
Yeah.
Combining.
It's been a journey, and we'll talk in more detail about the journey.
Yes.
And I just wanted to call out, Hoag is the highest delivering facility in California. So, over the last year, we did over 8,500 deliveries, and this year we're on track to do 9,000 deliveries. Just in the month of July, between both campuses, we did 108 deliveries. So a lot of patients are choosing us. 108 deliveries in the month of July, or 108, sorry, 806. Need my friend next to me right now. 806 deliveries just for the month of July. And so we take strong pride with our delivery volumes, because we know that we have to do it right and we have to give the best care to our patients. And we have pride in that, and we take it very seriously. Thank you for correcting me.
Yeah.
All right, next slide.
So respectful maternity care, what it means at Hoag, a big part of our culture and maternal care philosophy is to provide care that the patient directs. Dr. Brooks's favorite saying, Dr. Brooks is our physician leader, is nothing about me without me. So infiltrating that culture as we've gone through the collaborative has been huge for us, where we make sure every patient's treated with dignity, empathy, and respect. And promoting shared decision-making. We created a tool. Birth plan used to be like something that nurses would frown upon. Oh, this girl's trying to tell me how to do my job. Like, it would be that kind of comments. I'm sure we all hear it. Doulas, that used to, now we're like, bring the doulas. Here's our birth plan we made ourselves. This is how we go through this to make sure we are changing the power kind of in the room, and making sure that the patient feels that they're controlling their delivery and telling us how that's going to look for them, and making sure that we're creating personalized birth plans and care, making our care respect them and their needs. Ultimately, safe outcomes, cultural humility, and making sure that we listen. That's all it is. Sit down 5 minutes, and if we can do it in a hospital this big, this busy, you can do it anywhere.
All right, supportive awareness. So this is the start of our journey talk. So our journey has been a journey. We started it in 2023, and we started off with looking at our data. So we document in Epic, but there's a lot of different other systems that you can use. And in Epic, we have dashboards that are built up based off our nurses' documentation that can give us what our metrics are. And it was clear to see that we had opportunities for improvement with our NTSB rate and many other things, timely treatment of hypertension. So we really leaned on the data when we started our journey, showing that there's a difference and there's a problem. Utilizing the ACOG statement. There was a beautiful statement that came out a few years ago from
the ACOG position statement on equity for birthing people.
And we had it up in a meeting with executive leadership, and it was really powerful. Stakeholders. Our stakeholders on the start of our journey in 2023 look different than they do today. We had to pivot and adjust and make sure we had the right team members in the room, people that are motivated, passionate, not necessarily all within maternal child health, and really having that provider champion, Dr. Allison Brooks, she's amazing. And to have a provider with us through every single step, getting the other providers on board, having relationships and having these conversations of what opportunities that we had within our own teams is priceless.
And our quality department also was involved as well to make sure that we were looking at all of these metrics. And so when we had buy-in in these high levels of leadership, those of us down at the bedside felt empowered to really do this work. And we created goals from all of that work.
All right, I just wanted to shout out some available free resources that you can utilize. Every team looks different. Some are big, some are small. You may have a clinical ladder program, you may not. You might just have some motivated team members. So we'll be sharing these links out for each of these resources, but I promise you that someone can find something, whether it's an article to bring forward to their team or discuss at a staff meeting.
And I think that looking at all of these things are free resources. They give you really a guide on how to implement this. We use the Respectful Maternity Care Toolkit from A1, and the articles, the topics, everything's right in there to help guide you in how to implement this. But all of these resources are ones that I've looked at and leaned on as I've led our birth equity clinical ladder team and created topics for our meetings, our staff meetings, and our meetings in our birth equity clinical ladder team.
A resource, I always like to shout out what's free, right? It just sometimes takes the right people or your team. We had a lot of new charge nurses and labor and delivery in Newport specifically. And so the director, Jamie Lynch, got her team together and they created a statement. Their mission statement is their team. And one of the charge nurses painted this, and this is hanging on the wall in the director's office. And it's such a good centering point to remind us why we're here, what our vision and what our goals are.
I think one of the most powerful things when I was participating in the collaborative is Dr. Amanda Williams was speaking to us about how to kind of talk about these sensitive topics. And I think that these are a lot of things that will make people feel certain ways. And so you have to work in those assumptions and you have to teach your staff to be questioning and curious, be gentle. Work with the assumption that no one wants to be intentionally discriminatory. And Dr. Williams specifically used this analogy that your slip is showing. And she said, she would, it was something they used when they were younger, when they would go to church and they had full slips on under their dress and they'd be like, hey, your slip is showing. And so in these situations where maybe somebody is saying something ignorant or not being very informed about a patient population, to be gentle and kind of pull that person aside and be like, I know you care about your patients, and I know that maybe you didn't mean this, or maybe you weren't aware of this, but in this situation, this could be offensive, or maybe you made this patient feel like they couldn't speak up for themselves if you treat them a certain way. Remember that there will be pushback to use data and patient feedback to drive your conversations. Utilize your leadership skills about, tell me more about this, or help me understand what was happening, or help me, use all of your change management kind of skills and leadership that you use every day to kind of move your staff through these conversations and this education.
So we wanted to talk about what our most impactful interventions were. They all didn't present at the same time. It was a lot of reflection over the work that we've done over the last few years and being involved in the collaborative, but really acknowledgement of there's opportunities for improvement, whether that be through patient rounding or a patient story or something that was observed on the unit, through education, which Trina will go over in more detail, holding a birth equity steering committee with people throughout the organization involved. Truly that it takes us mentality, because it takes all of us. We're all invested in our patients and we all take care, from the EVS team worker to food and nutrition to our scrub tech, that all of us make a difference, and clinical ladder champions.
So the most powerful thing that we have found is utilizing real case studies, use storytelling to create engagement. I know that in nursing school, a vignette or a patient story would really get me engaged on looking at like, oh, what do I need to think about when I'm caring for this patient? How do I create a plan? Use case studies that occurred in your own organization if possible. In our organization, we had a patient with severe mental health disorder and substance use disorder. We had multiple transgender patients. We had a situation where a physician told a patient that her baby had jaundice because she was Asian. All of those situations have created conversation and driven change and driven education. I truly feel like the culture change it happens in little conversations in the hallway between all of our clinical ladder nurses who participate in birth equity. And now when we're giving report, equity is at the forefront of our brain. When we have a person of color or different races or a person who maybe their language, they have a language barrier or they're deaf, or they've experienced extreme trauma or different types of trauma. Trauma-informed care was huge in this work. And so all of those different topics fall under this umbrella of birth equity and utilizing those patients to lead our stories in teaching. It's really powerful. Next slide. So accountability is key. In our organization, clinical ladder status is you have to prove your use as a clinical ladder nurse. It is taken away if you don't do your clinical ladder work. So accountability is key. We have a large number of nurses with advanced degrees. We're fortunate in our organization that our organization pays for us to get advanced degrees. So critically reading research. Clinical ladder culture is strong and drives change and outcome. I would say there's healthy competition between our clinical ladder groups to make our education fun, engaging, and they even do things with email where they put GIFs in there and they like make them fun. Like one nurse did hers like through a Taylor Swift song and theme all throughout when she was doing education on Code RBC or Code Crimson is what they call it in a lot of other hospitals. But utilizing those things that are free. Staff meetings, our director plans our staff meetings out for the whole year for topics, so each clinical ladder team knows what month they're speaking. And we want our friends to be engaged in what we're speaking about, so they remember it. We use badge buddies, we use, all different types of low-cost things, even as simple as a bulletin board in our break room.
But I think also the pride that the clinical ladder nurses have with getting their team together, having a chair, co-chair, writing a SMART goal, and then owning that throughout the year. We know that Trina's the chair of birth equity, and we have a sepsis team and other teams. And if there's anything happening on the unit or clarifying questions that we might have, we naturally gravitate to those team members. So they're little champions on the floor, which is so helpful when we have big care teams.
And you have those small conversations about these situations happening all the time. Clinical ladder impacts, utilize a framework. We talked about that. These are the different ones. I went to an AWON conferences. I went to the Speak Up campaign. I did a 2-day class on that. Determine your cadence of your meetings. Utilize team members to provide education, email, staff meetings. We talked about that. And clinical ladder team members should act as a resource for staff. We kind of spoke to this on the previous slide.
I always like to say that the clinical ladder nurses are a secret sauce. And when I discussed that we restructured our stakeholders, we identified a gap early on that we were very leadership heavy managers and directors, and we needed some of the front line. And so just to tell you, a challenge is how big our care teams are across both organizations or both units. So this is our total of staff. So we have close to 170 plus clinical ladder nurses working on all different things. We're gonna hurry up.
And then our one of our biggest barriers here was this you want to speak to this?
Yeah, so getting our DEI survey complete and approved by leadership and working with patient experience and Qualtrics of how we are going to deliver this survey, as well as creating a birth preference sheet available for all of our patients in different languages. And that was co-created with many of our private community OBs and midwives. A lot of that took a lot of time, as well as a leadership adjustment. It was slow momentum at first, but we were able to complete that.
And then the next slide just shows you our timeline where we started our CMQCC journey up to now. So this has been a 2-year journey, and this is kind of how it went. Since we only have 1 minute left, we'll just keep going real quick. And then the next slide is just, this is the first clinical ladder board that I put up. Each month I put up a new article or things like that. But one of our team members made this logo for birth equity there.
But having a dedicated space with updated resources available for any team members that, to Trina's point, she always says, be curious, is a priority to our teams on all of our units.
Oh yeah, implicit and explicit bias. We didn't talk about that, but I think that one of my lectures to the staff was about that and taking the implicit bias test. So those kind of challenges and teaching your staff to be curious and think about things, not feel like they're being told that they're wrong and correct and all that kind of stuff. To be gentle, to let them think about this in a curious way. I think that's the hugest take home kind of.
And I just wanted to share, we have a large team, but this is our leadership team. And so I feel if the 5 of us can drive a lot of change on these big units, anyone can do it. And we'll be a resource if you're on your own journey and you want to talk about what support you need or what challenges that we had in more detail, please feel free to reach out.
Absolutely.
Thank you.
Thank you.
Thanks, you guys. I'm going to back up to your timeline screen, actually, because we want to spend like 30 seconds just explaining this a little bit. I think folks would really benefit from it.
Yeah, so in 2023, we started, our CMQCC journey, but mid-2023, I think it's important to call out, we had a lot of leadership changes. There was a lot of changes in culture within our unit. We had several new managers, directors, and I was even new in my role. And I think looking at things from different perspectives and angles is always a good way to hit restart or refresh on a project that maybe has slow momentum. And then looking to engage, executive leadership and having that provider dyad together with you at the table. Then in 2024, a lot of us made the decision, we need a clinical ladder group specifically on birth equity, and we're looking at the data. And so we are able to kind of lean in and get that accomplished.
And I think that the clinical ladder group owning that takes it one out of the leadership's hands, because I think that projects like this, because they're not, they can get deprioritized. And so letting the staff own this, especially since they're the ones dealing with it, was important. And we kept, with their partnership, so that they could speak in the higher levels, we could disseminate, but also prioritize what we needed with our goals. So part of our clinical ladder team is required to make a SMART goal. And so being able to kind of plan out the year and look at that helped this not to fizzle out, because we were having to meet on it and being held accountable by our leadership.
It's a good sustainment plan,
it
right?
Does. It forces you to sustain.
Sorry.
Go ahead.
I was just going to say, though, I think the one thing I love about the clinical ladder group is because we onboard so many nurses every single month going to sustainment plan, we've incorporated it into hospital orientation. So every new staff member that joins Hoag Maternal Child Health will get, educated on everything that we're doing and that the clinical ladder nurses are doing. And so by keeping this clinical ladder group going forward, we have regular report outs at staff meetings. We have our birth preference sheet. So a lot of the work that's being driven is what we're hearing from our patients, where there's gaps and opportunities.
And I think like our fellows we have such a large staff, we onboard new to labor staff twice a year, and it's usually 10 to 12 people. And so we do each clinical ladder group does a 2-hour presentation to them. So that helps infiltrate it into the culture. They know from the get-go that this is priority. And then we do it during our preceptorships. When we're precepting, we make sure that that's part of our onboarding so that they understand that this is a priority in our organization.
Which is helpful for a sustainment plan and also centering, because our teams are so big, of what respectful maternity care really truly means at Hoag.
Oh, in team care huddles, we forgot to speak to that. So team care huddles are something when a charge nurse or a nurse feels like there's too many conversations going on between maybe MFM and the NEO and the primary OB and the hospitalist, and nobody's on the same page. We'll be like, hold on, stop. And we call a team care huddle. Everybody gets in the same room, and having equity be part of that conversation of team care huddles is super important as well. I think we forgot that little point. We had it in one of our slides, but we're trying to keep this time limit.
So like I said, we're available if anyone has any questions,
or if you want
about
more
anything.
detail about something or how we implemented this, or less high level and more in the weeds kind of stuff, like how to, let us know about that. We're happy to help.
Thank you, Tiffany. Thanks, Trina. This was an amazing presentation. Terry and I are huge fans of what you guys are working on. I will make sure that your emails are posted on this slide when we post the slide deck and the recording for everyone, so they can get in contact with you if they have any other questions. But if you have any questions for them, please drop them in the Q&A really quick. We'll only have a few more minutes, so I'm going to go through a couple of our other slides. But if you have questions for Tiffany and Trina, please go ahead and drop those in the chat and they can take a look. Thank you to our presenters, to both of the teams. You guys did an excellent job. We are so proud of the work that you're doing. We're so grateful that we got to be a part of it. Thank you for joining along with CMQCC. If anyone listening is a California hospital that's part of CMQCC, if you're interested in learning more about the Learning Initiative, or if you are ready to be on a recruitment list or an interest list for learning more, you can contact us at info@cmqcc.org. We are launching round 4 of the cohort groups in the fall, so just in about a month or so. So if you're interested, let us know. We'll be launching round 5 in the winter. So if you are interested, but maybe not quite ready to jump in with both feet, you can let us know, and we'll definitely let you know about the winter details. Wanted to also highlight that we have a revised CMQCC sepsis toolkit coming out at the end of next week. The webinar is on September 5th. You can register with the QR code here on the right. The toolkit will be available to download as well on September 5th. So we hope that you will join us for the webinar and the toolkit release next Friday. We're really excited about the work that's been going into this, and we'll be excited to see you all there. You know where to find us with CMQCC. You know, we have our toolkits. If you need any questions on implementation, our data center, or engagement, you can find all of those details at cmqcc.org. Or you can follow us on Facebook, Twitter, YouTube. You can email us at info@cmqcc.org as well. If you have any other questions or anything, you can put them in the chat or in the Q&A box as well, and we can get to those. But thank you all for joining us. As a reminder, the slides will be posted on cmqcc.org in the next couple of days, along with the recording. So if you have any other questions or need anything else, you know where to find us. Thank you all for joining. I think that concludes our webinar for today, but I'll leave the webinar open for another minute or two if you have any questions for Ayla and April. Thank you all for joining. This was lovely to have you all here with us.